male students tonight. So I'll just say, gentlemen, if you have not been here before, I'd like to introduce you to our Associate Medical Director, Dr. Donald Phillips. Dr. Phillips has come to us after many years in EMS. He's a prior paramedic. Are you still certified as a paramedic too, Doc?
No, I had to let that go when I was in Missouri.
But anyway, he's still a medical director for Life Care in Weatherford. Yeah, there we go. And emergency physician, been around for many years, and he is Dr. Frame's up and coming right-hand man. So it looks like tonight he is tackling one of the topics that we've had identified on our P2 final exam as being a problem area for elder abuse. So that having been said, I'm going to turn this over to Dr. Phillips. However, I will point out that I would like you to keep your microphones muted unless you have something to say or a question to ask, and Dr. Phillips may check throughout to make sure you're still there. We'll be checking toward the end as well. You need to still be here to get credit. You need to be able to answer either in chat room or by using your microphone. But once you do speak with the microphone, please mute it again so that your ambient noise doesn't bother everybody else in the room. And at the end or close to the end, for everyone who has participated, I'll be granting credit to your MD Roundtable. If your MD Roundtable is full, but your chat rooms are not, I'll spill it over to there. If you are in 300 like Jesse Sola, then as long as you have open spots on your chat room there, I will grant you credit there as long as you participate. So have a good time, and I'm going to mute my microphone.
And so guys, if you have questions or comments that come up, I do have the chat window open, so I'll see those. That's one of the things that I'm trying to get myself in the habit of doing, is opening my window. So for those of y'all that were with me last time, we talked about the uplifting topics of intimate partner violence and child abuse. So we're going to continue in that vein with these really, really uplifting topics, and we have elder abuse to start with tonight. We're going to cover two areas, mostly so that we can try to get these things done. So we're going to be flying through this stuff. So just bear with me a little bit, because there's a lot of redundancy in this, and you'll see that as we come along. And so hopefully we can get through these things pretty easily. So first one. Elder abuse can come in several different forms. Of course, everyone thinks about the physical abuse, but neglect is an area that really is probably more common than any of the others. And this includes self-neglect. So you need to understand that sometimes these people are not taking care of themselves, and also financial exploitation. So what defines an elder? Well, it varies a lot. And so wherever you're at, you need to find out what that definition is for that area. But most of the time, it's somebody that's 60 to 65 and older. And also, sometimes they will include in there people that have certain disabilities. So abuse is a willful infliction of physical pain or restraint, willful non-consensual contact that's sexual in nature, or psychological harm. Neglect, well, this is when their needs are not being met, especially if there is a caretaker that should be taking care of those people and they are not meeting their obligation to those folks. But keep in mind that this also encompasses self-neglect. So, like I said, a lot of definitions here. Abandonment. Sometimes people don't stay around when they're supposed to. Sometimes they are leaving these folks that are vulnerable alone overnight or at other times. We've all heard stories about the family member that is keeping grandma at the house with them so that they get the Social Security check. That is an example of financial exploitation. Certainly if the elderly person is married or has a partner that lives with them, then there could also be mistreatment in the cases as well. The one that, frankly, I was kind of surprised to see how prevalent it is the institutional maltreatment. Not really because of anything other than I just never really thought of it as being that. I just kind of put that in a separate little category, but it is considered part of this. And then what is the definition of the vulnerable elder? Well, that's somebody that usually doesn't have has some cognitive disabilities that makes it so that they have trouble taking care of themselves. Who is a caretaker? This is somebody or an entity, so in the case of like a nursing home, who has a duty or whom it would be reasonable to conclude has taken on a duty to care for and to protect that person. An example of that, when my mother was still alive, she had a caretaker that stayed with her 24 hours a day. We actually had 4 of those that took shifts to do that. And so they would be an example of a caregiver or caretaker. So then this definition of polyvictimization. So this is when there's multiple people doing the same thing. So in other words, you know, a family that isn't taking care of grandma. Capacity. Now, this is something that we really try to spend more time talking about, not just in the case of the elderly, but even in mentally ill people. Do they have the ability to make and carry out the decisions about their own care and protection? So there's 2 things about this. One of those is the decisional capacity. Do they understand all this stuff? Can they understand the information that we are giving them? Can they understand the situation and why it's important? And can they figure out the treatment options? But then the other one is the executive capacity. And this is really more, and I know it's split here in a lot of ways, but this is really one of those where do they have the cognitive ability to understand that particular thing? Let's see. Okay. Different chat there. So, so just remember that anytime that somebody is refusing care or what we have recommended, and that doesn't necessarily mean that they're saying, you know, that they're refusing everything, but certain aspects of anything that we say that we should do to care for a pre-hospital patient, we really need to document that they have the capacity to understand the choices and the decision, and also the executive capacity to execute those things. And the executive capacity may also include, are they their own guardian? So sometimes there's a person that they have guardianship for the person. So we need to keep those in mind. And like I said, this is an area that we probably should spend a lot more time in, just to make sure that everyone understands that. That may actually be a half an hour topic in itself. So protections. Once again, every state has laws, and there's different agencies that are set up to do this. Most typically, it's called APS, Adult Protective Services. And then there's also certain states, ironically, Texas is not one of those, that has protections against self-neglect. Now, it's kind of a gray area because it's if we have somebody in Texas that is not able to care for themselves, procedures that can be taken in order to get them to where they can get the care that they need. And then there's also these things in the institutions, long-term care ombudsman programs, if I can talk for a second. And these folks tend to investigate problems in nursing homes and other institutional settings, and then they turn their findings over to APS. And once again, these are agencies that are there to try to protect them from other adults that may mistreat them. And so we're talking generally, especially with the LTCOP, about nursing homes, but APS is also there to help address families that may be neglecting or abusing an elder. So let's talk about how prevalent this stuff is. So North and South America, it's hard to get a lot of information about this, and especially localized sort of information. But you can see here that they said that in one multinational study in North and South America, 6% reported abuse, and nearly 25% report psychological abuse if they're dependent on a caregiver. Now, I don't know the methodology for this particular study that they're citing, so it's kind of hard for me to comment more than just telling you the data that came out. But in 2005, 41% Medicare beneficiaries had difficulty performing their ADLs, and they potentially needed support. 41%, that's almost half of all the people that are on Medicare back in 2005 needed some assistance from either paid or unpaid caregivers. And once again, a lot of elders don't get the medical and social care that they need. Sometimes it's because they don't know that they need it. Sometimes it's because they don't have the ability to get to those situations, such as that 41% that we were talking about that need help with ADLs. But this is a form of self-neglect. So there is underreporting. I think that that's probably something that will always be there. And you'd notice that self-neglect is the most common condition among the reported cases. And this is because typically these are things that are easier to see. It's easier for us if we come into a home where somebody is not caring for themselves. We can see that there's no food in the refrigerator. We can see that their heat is not working. So there's things that we tend to pick up on. The problem really is when it's somebody else that's abusing or neglecting them. So here is 1996, 551,000 in the United States, but only 21% were reported and verified. And 38% of those were neglect. So once again, it's a very common thing that we see. And then the National Center on Elder Abuse surveyed all of the APS agencies in 2004, and you can see the numbers there. 39% were self-neglect, and then caregiver were 21.5%, and 14% were financial. So there's quite a bit. Now, this is the one that just really, I was unaware of how prevalent this is the institutional maltreatment. 1.6 million people in 17,000 licensed nursing homes, and 900,000 more that live in residential care facilities. That was in 2002, and I feel like there's probably many, many more. I think that this is an area that has grown exponentially over the last several years. And about a third of nursing homes were cited for abuse violations, and that was just in a 2-year period or 3-year period from 99 to 2001. And then in 2008, you can see the number of complaints there. 78% were related to nursing home care. So, it's a big problem. And then this is a breakdown of what those percentages are. And once again, in nursing home complaints: failure to respond, injury of unknown origin. And I know I see a lot of people that fall at the nursing homes. It even has its own ICD-10 diagnosis code: fall at nursing home. Staff attitudes about dignity, symptoms are unattended to, property was lost or stolen, staff unresponsive. I'm not sure why that one's separate from the failure to respond to requests for assistance, but it is. Physical abuse, 1.8%. That's a lot. I mean, it's a low number there, but when you consider the total number of complaints, that's a lot. And then resident to resident abuse, that's something that I see occasionally. Somebody gets injured and they say the 2 residents got into a fight. And then you see the others, verbal and mental abuse and gross neglect. And the numbers are pretty much the same for assisted living and residential care centers. So how many die or get sick from this? It's hard to know because, once again, this is an underreported sort of thing. But 1.7 times greater chances of you dying from self-neglect, but 3.1% if you're abused or exploited. And once again, keep in mind, especially with the self-neglect, it may cause your loss of independence. It may mean that you're having to move out of your home. You may end up, especially if your family situation isn't good, you may lose family support, especially if they were the ones that were exploiting you. So, there's a lot of factors at play in this. So let's talk about the risk factors. Generally, it's going to be a female over the age of 80, and the abuser is usually a spouse or an adult child. And it's more likely, unfortunately, to be related to African American race. For self-neglect, more than whites more often. So in other words, if you're black, you're more likely to be abused by somebody else. If you're white, you're more likely to be neglecting yourself. And once again, difficulty caring for yourself is kind of an automatic in most of these cases. And a lot of folks with dementia, the family will try to keep them there a lot longer than they should, especially if they're financially exploiting them. And then once again, depression is a very common sort of thing. And then once again, these are some more of the risk factors. So in other words, folks that have had a stroke or a hip fracture, because they tend to need somebody to help them perform those activities of daily living. If they're isolated, if they're poor, if they have other family stresses, then those are things, especially it tends to be family financial stress. They tend to try to use whatever resources, and those tend to be the financial exploitations. And then once again, if the caretakers are abusing substances, or if they have mental illness, then those tend to be factors that are not good to have around. Nursing home situations, if there's staffing shortages, and practically every nursing home does have staffing shortages. And then I thought it was interesting that if there was already a history in the family of child or intimate partner violence, they're much more likely as well. Let's see. Tell you what, let's see does anybody have any questions right now? Let's see. Trevor, do you have anything?
You guys can just unmute your microphone if you have something to say.
I do not, sir. I think you're doing a good job.
Okay. So Mark
I had a question.
Sure. Who's that?
It's Derek. He had a question about capacity as it relates to guardianship when somebody's at a facility calls and said this person's being aggressive, whatever. Is asking to leave, and the facility is saying, basically they're requesting to leave, and we're telling them no. It would be kind of like an AMA situation. But the person they say the other person has a guardian, though they're not able to make these decisions. You show up, and the person obviously is AMS, but you don't have the same kind of data, dementia versus anything from UTI, med changes, maybe this person's an underlying psych condition, and the facility saying we don't want them to leave, but they're requesting to leave.
Okay, so you kind of cut out a little bit. So are you saying this is a person who already has a guardianship that's been established for them, or somebody that does not?
Yes. Well, I mean, we could talk about both, but if somebody has a guardian, the facility is saying the patient wants to leave. They're being more combative, more aggressive, that kind of thing. So we're not going to stop them, but they do have a guardian, and we're not sure if they have the capacity to make a decision.
Okay, so in the event that there is a guardianship that has already been set up, and most of the time these are through the courts, in that case, that patient cannot make that decision if that guardianship has been activated. If they have a power of attorney So in other words, before they lost their capacity, they made the decision to set up a power of attorney that would make those decisions for them. Then if that has been activated, then at that point, they no longer have that capacity. My mom, we didn't have to set up a guardianship for her, but before, years before she got sick, she had set up to have myself as her power of attorney for all decisions, for healthcare as well as financial and everything else. And so once we decided, hey, mom's not really making good decisions right now, we're going to invoke this, and we made that decision, then at that point, she could not do anything without my approval in that particular case. So a nursing home has a duty to care for that person. Just because they may be acting out, if there is medical to be transported, they can't just tell them to go, and they can't just let them go in the case where there's a guardianship that's already been enacted. So in those situations, the guardianship takes precedent. Does that make sense?
Yes, thank you.
Okay. So Mark has here, I get the followed nursing home, but some of these patients don't get turned and develop pressure ulcers. Absolutely. That is a form of neglect. And as far as how you know whether they were there before or not, it's going to have to be in their charting. Certainly we at the hospital level can look at these and in some cases determine based on how bad they are, if they are something new or not. But we a lot of times will rely on whether or not there's charting that establishes that, hey, this pressure ulcer was already there before. And it's been being cared for, and is there a doctor's note from wound care or somebody like that they've been taking care of this appropriately? It's an excellent question. And so I think that it's more a matter of if we pick up these patients and take them to the hospital, pointing out, hey, when we rolled her over, there's actually a pretty big pressure ulcer on the sacrum, or the right hip has an area that's reddened and it looks like it may be starting to get to be a pressure ulcer. Y'all just need to take a look at it. You need to document it in your chart. I would not necessarily try to stage something like that. And the main reason is that if something like that ever goes to court, believe me, they will make any of us, including myself, look like a total idiot on a witness stand if we've charted something and we're not that familiar with it. It's a lot better to say something to the effect of, there's an area of erythema and appears somewhat shiny in appearance, or there's an ulceration that is depressed there, that is open, that has discharge, no discharge, foul odor, no foul odor, something to that effect. So rather than saying stage 4 or something like that, it's a lot better to just go ahead and describe it. I got in trouble when I was a resident because we had to take an examination when we finished our orthopedics rotation, and they wrote, if you call the orthopedic surgeon and describe a fracture of the radius along with the dislocation, or a fracture of the distal ulna along with the dislocation of the proximal radius, what would you say? I wrote out their description. And they were like, no, we were looking for, and I'm like, no, you told me first day, describe this, don't tell me a pseudonym for it. So they actually ended up having to give me the credit for that particular question because I followed their directions. It's always better, because if I said it was Galeazzi's and it wasn't, then they would end up being upset and they might have called in the wrong people to take care of something. So once again, describe it as best you can. Okay, and I know that gets tedious at times and can be somewhat difficult. Were there any other questions? I know I'm not that clear. Okay, so let's go ahead and move on. So inappropriate medication issues. So it may be that they have the wrong medication themselves, that they're taking that they should not necessarily be taking. They may be taking too much or not enough of a particular medicine. It may be being unmonitored. So in other words, the patient may be taking medication that they probably should have somebody looking to make sure that they're taking it appropriately, and they're not. Sometimes, certainly in the case of things that can alter somebody's mental status, they may be being diverted and sold, or they may have difficulty getting their medications. So what do you want to look for? Okay, this is really the important part here for us. Okay, what is going to clue you in to some of these things? So bruises, tears, burns, fractures, those are pretty obvious. Malnutrition, on the other hand, and dehydration may be something that is a little bit on the difficult side for us to pick up. You know, there are times that my crews will tell the hospital, hey, you know, while we were there, we just went ahead and took a quick look around the house, and there's no food in their fridge, or their pantry has got nothing good in it, or there's nothing but rotten food in the house. You know, those are clues that there's something going on. Certainly the decubitus ulcers, especially in somebody that's being taken care of in a nursing home, is something that, you know, needs to be looked into. And yes, sometimes these folks are sexually abused. So if they're complaining of pain in their genitourinary area, if they have evidence of a sexually transmitted disease or an STD, if they have bleeding in those areas, especially vaginal in an elderly woman, you need to start asking about those things. So, reporting. We are mandated to report this stuff, okay? Like we talked about with the pressure sores, careful documentation of these things, because it could end up going to court. Notify law enforcement and APS, and always tell the receiving hospital, hey, you know, we think there may be something going on. And don't rely on a hospital or anybody else to call APS. Call APS or call law enforcement. You can always document that you notified law enforcement of the situation, but the best would be to put in your chart, I called Adult Protective Services, or whatever the acronym for your area is, to let them know about the situation. Understand that they're not probably going to come out to the house right then and do much, if anything, but it does get the ball rolling, and that's something that we need to take care of. So, any questions on elder abuse before we get into this next wonderful, uplifting topic?
Pretty quiet.
Yeah. Curtis, you have anything?
No, sir.
Okay. How about Jesse?
Yeah, I had a question. On a call, if you notice that there's no food in the refrigerator, or it's a pretty bad environment, and there's family members there, how are you supposed to tell them that you're gonna look through the fridge and see if they have any food for their parents?
Well, you know, that's actually
I've been in a call like that before, where it was just awkward, and I didn't want to just open the fridge.
Yeah, that's an excellent question. You know, one thing that I have seen done, I didn't think of it, so I can't take credit for it, was, yeah, are they on insulin or anything? Let me just take a look in the fridge, because that's usually in the refrigerator. You know, gives you an opportunity there, you know, just to say, okay, you know, we're looking at all their medicines. You know, I tell my EMS guys, you know, take a grocery sack, go into their medicine cabinet, and just, you know, take your hand and put everything into the bag and bring with you. And there's several reasons for that. One of them is, you know, so that we can actually count the pills and make sure that they're taking the things appropriately. The other thing is that we can hopefully tell, okay, is there something that they should not be taking that they are taking? You know, and I got started doing this when I was still up in Missouri and was a medical director there, because especially one of the hospitals, they wanted us to bring in every pill bottle, and they would actually sit there and go, okay, they're ready to be discharged. They take this one, they don't take, they don't take, they don't take, keep taking this one, keep taking this one. And they would separate them for the patients so that they knew which ones they were not supposed to be taking. Then they would offer to dispose of the ones that they weren't supposed to be taking, just so that there was never any question that, am I supposed to take this or not? But once again, the insulin question is always a good one. Do they have a history of diabetes? Let me just look in the fridge and see if there's any insulin in here, because most insulins are stored in a refrigerated environment. The other thing that sometimes you can say is, you know, hey, listen, you know, Vial of Life. I don't know if any of y'all have heard of that or not, but Vial of Life is a service where they take some important papers and things such as DNRs, medication records, those sort of things, and they put them into a special container and then put it into the refrigerator. And the reason for the refrigerator is everyone's got one. It's an easy location to find. And if there's a house fire for some reason, generally what's in the refrigerator is preserved. So, you know, there are numerous ways that you can go about asking that. And so, you know, I don't know if that answered your question or not, Jesse.
Yes, it did. Thank you, sir.
Okay. Anything else? Okay. So human trafficking. This is one of those things that is very, very difficult to find. I've had EMS at the hospitals that I've worked at that several times have brought in patients and they've said, you know, there's something about this that just kind of sounds like they're being trafficked. And it's probably about half of the time that we agree with that, but a lot of times it's a difficult thing. So first off, definition, and I'm not going to read this whole thing to you, but if you notice down here, exploitation shall include at a minimum the exploitation of the prostitution of others or other forms of sexual exploitation, forced labor or services, slavery or practices similar to slavery, servitude, or the removal of organs. So it's a very all-encompassing definition from the UN, but basically it's modern slavery is really the best description of it in a nutshell. Keep in mind that this does not require that the person be moved. They can be living in their own home and being trafficked. So there's a lot of different things involved in here. There's no good numbers. Everything is estimated, but you see in 2016, the UN estimated 40 million people in the world are involved in the victims. 25 million in forced labor. Now, I'm not sure about exactly what their definitions are for this. 15 million in forced marriages, and they estimate 152 million between the ages of 5 and 17 that are in forced labor. So it's huge numbers. And then in 2015, this is just in the United States, 1 in 5 runaways are forced into sex trafficking. So there's 4 different levels of risk factors that need to be at least thought about, and that is the individual, their relationships, the community locally, and also society at large. And so these are all different things that, depending on the situations that the people are in, can play a factor in this. And poverty increases the risk everywhere. The biggest age group is 12 to 16-year-olds. These are the runaways, okay? Racial and ethnic minorities, rural. That was something that to me was actually kind of a surprising thing, because, you know, it's one of those, we don't usually think about runaways or throwaways being a big problem in the rural areas, but this is what the UN and the medical experts in this area say. Low education, so somebody that's dropped out of school or other situations that have led them to that. Disability, poor family support and protection, and migration, so somebody moves along. Derek points out, yes, lots of non-white people are involved in this. There's a lot of people that are in that ethnic minority and racial minorities group. So marginalized persons. So once again, these are folks that have some of these alternative sexual orientations, the runaways, the throwaways, migrants, indigenous persons, and abused children. And this is a direct quote, and I thought that it was an important one. In the United States, these people come from all socioeconomic levels, including citizens, non-citizens, documented, undocumented. It's everything that you can think of. So in general, they're abused or coerced, and this includes being drugged. And so a lot of these folks may be being given drugs against their will. It has a lot of consequences, especially on their mental health and sometimes physical consequences. But especially they're prone to depression and anxiety, a lot of suicidal ideation. And once again, they're often given drugs or alcohol so that they can be controlled. Especially in those that have been sex trafficked, they have a lot of suicide attempts. It's a heartbreaking situation. A lot of these folks have HIV, and a lot of times you're going to have to ask about their medications or just simply test them to know if that's the case. A lot of times they have sexually transmitted diseases, pregnancies, and also forced abortions. Labor trafficking. Some of the problems, and once again, it says it depends on the labor. So what kind of work are they being forced to do? But they may not necessarily be in the best of or safest of situations. They may not have any safety equipment or protective gear. They may be exposed to infections. They may not have an area where it's warm in the wintertime or where there's any kind of cooling in the summer. We all have heard stories or read about body packers and some of the things that can go along with that, including rupture of the packages. And certainly if they are traveling overseas, there's travel risk, including in certain countries, they may end up, being caught and being, either shot or hurt at the same time and not necessarily given the best of situation there. So really, for this particular topic, I want you to think about some of these things that will help with us identifying these folks. Now, first off, we've got the barriers. What's going to keep us from identifying some of these people that may be being trafficked? Certainly, fear of the one that's abusing them has got to be the first thing. But a lot of these folks also don't trust police departments or even medical personnel. Now, EMS may be in a unique situation because for most people in most countries, they recognize that EMS are healthcare providers and not necessarily part of a police department, even though they may have a uniform on. So we may occupy a special role in that particular area. Certainly there's shame associated with this. They may have, the trafficker may have threatened their family. Certainly deportation is a thing that hangs over their head all the time if they're immigrants. Who knows what the Stockholm Syndrome is? Somebody unmute and tell us what you think that is.
It's whenever someone doesn't have to be kidnapped or anything, but they've been held captive or with someone so long that they kind of become emotionally stuck to that person.
Right. Excellent, Philip. That's exactly what it is now. It doesn't have to be a long time. Stockholm syndrome doesn't take even a day necessarily to cause that. But if there is a significant threat to the victim that is also shared with the perpetrator, then they sometimes will actually begin to identify them. So certainly, the longer that they're with them, the more likely that is to occur. Sometimes, and this next point is true, they may not realize that they're being trafficked. They may think, well, yeah, I'm getting something for this. They're housing me, they're giving me food. So there's sometimes where they don't realize what is going on with themselves, or they feel like disclosing it is going to cause them harm. So the things that we need to start kind of thinking about, or at least should make us start to question, could this be a case of human trafficking? Late presentation, so somebody that comes in 3 weeks after their acute injury, or some other late presentation of something significant, where most folks would come in pretty quickly for that. And we have that at times anyway, where people just, well, I thought I'd give it a few weeks. Discrepancies between the history and the physical examination. So there's times when what they're telling me happened doesn't make sense with what I'm finding on my physical examination. Okay, Mark, excellent question, and we'll go over that in a little bit about how to separate the victim from the perpetrator, because that is actually something that really needs to happen if at all possible. Women or even men that have recurrent STDs need to ask about some of those situations. Those are difficult things to ask, and for the most part, I don't expect that EMS is going to be the one to make those particular types of diagnoses. But at the same time, it's something that you need to keep in mind if they have multiple pregnancies or miscarriages. So this is a very busy slide, and I hope that you'll come back and you'll look at this particular MD roundtable and actually sit here and go through some of these things. I'm not going to go through all of this, but this is actually from the National Human Trafficking Resource Center, and this is the red flags that you need to look for. So if you have some of these things, you need to take note of it and talk about it when you get the patient to the hospiel. And then here's some more warning signs. Yeah.
I was going to say, yeah, you just hit the nail on the head there. We've encountered a lot of times in the hospital when the person gets their formal evaluation, whether it's in the ED or on an inpatient unit, that we go back and look at the EMS run sheets, and we discover a lot of information that the patient did not disclose while they're inpatient or at the hospital that they did disclose to EMS providers, and that really paints a significantly different picture or fills in a lot of questions.
Absolutely. The couple of, I guess it was a week and a half ago, I had my last shift up at this hospital in Ohio, and we actually had EMS come in and say, something that she's telling us is making us think that she's been trafficked. And, once we actually sat down and said, okay, well, come over here, tell us. And once they started talking about it, it was like, okay, we'll definitely address these things. And she swore up and down that she was not being trafficked. And, unfortunately, we'll come to that in a second, but that is one of those things that unfortunately does happen. So, but thank you, Derek. Definitely the case where if you have information like that, I always want you to come and talk to me, talk to one of my colleagues, pull us aside and tell us what your thoughts are, please. So, once again, the main thing for us is that we're there to provide good medical care. And I love the quote, I stole it, we want to make every patient feel that they are safe, secure, cared for, validated, and empowered to disclose if they choose to. Okay, there's no way that we're going to be able to force them to tell us that this is going on. But the things that we can do is open-ended questioning, maintaining good eye contact, and that's sometimes hard because they don't want to look us in the eye. They feel a sense of shame in a lot of cases, and so you have to kind of sometimes, it's okay to talk to me. I need you to look at me when we talk. Things to that effect. Not necessarily pushing it, but making that effort to go into it. And once again, questions in private. Now, there are a lot of times that I will tell, it's easier with an adult to say, I need to do part of the examination that I need you to step out for, things to that effect. And even in an EMS situation, we're going to take her to the truck for a second. Can you stay and talk to my partner? And he's going to get some further information, but I need to do some of this stuff in private. And those are the times to ask those questions. The other, especially with the child, it's time to get them to separate from the child. And if, especially in an EMS situation, you may never have that opportunity to be able to separate like that, especially with a child. That's okay. Don't let that take your level of questioning about this down. At that point, that's where you need to say, okay, you know what? This is not the time for this. Let me just get this patient to the proper setting, and I'll make sure that I relay my concerns. Once again, always maintain confidentiality. If you tell the patient that you will never reveal this to the supposed perpetrator, you cannot divulge that. The biggest thing that I see as a problem is use of family and friends as translators, because in those situations, it may not be translated properly for you, either by mistake or by resistance on that person's part. So, it's always best to get law enforcement or somebody else, if there's a translator available, and say, can you take them aside for a minute and let's just talk to them separate. But the family and friends, unfortunately, it's so easy to use, and we do it in the hospital sometimes, and we shouldn't. So physical exam findings, and we're not going to spend a lot of time on this, but the biggest thing is unexplained injuries, okay, or things that are in various stages. So in those situations, you really need to think, hey, there may be something else going on. I can't say that I've seen anybody with a barcode tattooed on them other than some of these people that are anti-government sort of things. But certainly, you should think about those sort of things, and especially certain tattoos in certain areas of the country. If they have evidence of strangulation, genital trauma, and I can't say that I've ever had somebody tell me that they've got an RFID chip that's been implanted in them yet, other than voluntary. And then occupational injuries that don't look like they're related to legitimate jobs. So I can't really think of a good example of that other than maybe my meth lab blew up, but that's usually their own lab, not something where they're being forced to work. So the reporting, once again, if it's a minor, if it's a child, those have to be reported. You don't have an option on that. The next thing here, this National Human Trafficking Hotline, this is something that you can use, but it's also something that you can discreetly pass along to the patient. And I especially like the texting, because all that you have to do is text help or info to be free. That's what the 233733, that's what that translates to, is be free. And then there's How many of y'all are familiar with the Quick Trip Safe Place program that they have in place? It's been there, and I didn't realize since 1991 that and I've seen the signs at Quick Trips when I go to them, safe place. Okay, I mean, yeah, I see that at different places, but in their case, they're saying that if you are a runaway or somebody that's at risk, then all that you have to do is identify yourself to one of their team members. They will put you, they don't have safe rooms. That was one of the rumors, was they had a safe room that you could go and get locked into until somebody's there to get you. But they will make sure that you get something to eat and drink and a place to wait. And they will contact the National Safe Place and get somebody to help to take care of you. So these are things that we need to be able to pass along to folks so that they, even if they decide not to go through with reporting or admitting or telling us these things, we can give them a way to get out of this if they decide to, or when they decide to. Hopefully it's when they decide to. So that's the end of that. Let's see who has some questions.
This is actually Turner Walker. Me and Chris are sitting here together, like I told you. I had a comment about the Quick Trip thing. Right close to where we live at is they have a bunch of Quick Trip gas stations, and it's in Fort Worth, and that's where MedStar, an EMS service, runs out of, and they actually post their ambulances at Quick Trips all throughout the city. So that's a great thing that they do, where somebody's there that can help them, should they come in and need that attention. So I think that's a pretty cool thing.
Sure. Yeah, I'm not sure that necessarily MedStar did it for that particular reason.
No. It's just where they post it. It's convenient.
But it is, right. Yeah, it's a nice way to be able to say, okay, well, if nothing else, let's get you over here. Let's get these guys to come and take a look at you real quick.
Yeah, absolutely. I just think it's a cool thing that they post there quite a bit. So all around the area.
Okay. Surely there's some other questions. Kevin, we haven't heard from you tonight.
I haven't really got a good question right now, but I did find it super interesting. I had to really think about it, why rural areas would actually suffer from more of these type of kidnapping and these type of situations.
Well, and part of me wonders if it's not just simply because that they're counting that as, well, the kid lives on a farm, and so dad uses him to help with the farm. I don't know.
I was also thinking. I'm sorry about
on
that.
Before you go to that thought, I did post on the PERCOM Facebook page, and I don't know if you use Facebook, but I posted the other day a link to a Texas Department of State Health Services CE course on human trafficking. That is an excellent course, and it actually has venue little, I don't know what you call it, where you show the little mini stories from many smaller communities in Texas that have been hubs of trafficking. And so if you go through our Facebook page, you don't have to go very far down and find that link. I went through that course, and it's an excellent resource for information for what you're asking about.
Okay. I guess also it's one of those where they can hide in plain sight sort of things.
And that's a big thing is that they made a point of, these people are there, the house, whatever, they start paying attention, seeing all the traffic going in and out. But some of these places were there for years before people even discovered they were right there in their own communities.
That's scary. Kevin, did you have anything else to add there?
Not really, but I'll definitely check out that information and CE site kind of that you posted.
Okay,
thanks for the information.
Excellent.
I got a question for you.
Go ahead.
Do you think that some of the trafficking stuff here in rural areas and/or rural areas that have low income think that has anything to do with it. The type of people that are living there, some of the stuff goes unnoticed because nobody really wants to report anything or draw attention to the area that they live in.
Yeah, that's a good question. Having lived in rural areas, I can't really say that I think that that's necessarily the case, especially if it's somebody from outside of that rural area that is doing the trafficking. I think that there is probably some element of, call it the low education side that may be playing a part in that. And I don't mean that in a derogatory fashion. It's just that in those areas, you're less likely to have, folks that have doctorate or master's level education. And they tend to, as we talked about earlier, they social distance anyway. And so, the big thing is, I mind my own business, and, I expect everyone else to mind their own business, sort of thing. So I think that probably plays a part more than we would care to admit.
Absolutely.
One of the things that I saw on that video, and you'll enjoy it on that class, was they showed that. But I don't know how many of you are familiar with the Woodlands, which is one of the wealthiest communities north of Houston.
Oh, yeah.
One of the big drug trafficking rings that they busted was from a house in a cul-de-sac in the Woodlands.
Hiding in plain sight.
Absolutely.
Exactly. That's exactly what they were doing.
Yeah. Well, and, especially if in the drug trafficking side of it, in those cases, it's also, you can have the flashy car in those areas. It's kind of hard in some of the other areas to have, fancy, expensive car and a nice house, but that's a way for you to, I guess, in a sense, launder the money.
Mark Schmidt, I've been trying to say this. You had posted a question earlier on the chat over there, but I don't know if you got an answer or not. Did you get an answer?
Yes, ma'am, I did.
Okay, I just wanted to make sure. Okay, who else have we not heard from? We've heard from Jesse and Derek, Curtis, Philip Munoz. Have we heard from you?
Yep. I remember Philip chiming in.
Okay. All right. Anybody else have anything for Dr. Phillips tonight?
That dishes class that you were talking about, Jane.
Yes.
There is a TCOL equivalent in the state of Texas that's actually mandatory for every police officer to take.
Yes.
I took it, 6 months ago. And it focuses more on the criminal side of it, but it's actually mandatory. You have to take it.
That's interesting. This one that I'm talking about is actually geared not just toward, law enforcement or EMS or fire, but general public as well. It's kind of a public service thing as well. And there are actually organizations, trucking companies, taxi services that make their personnel take the course and actually become more aware so they can be part of the solution because they're on the roads all the time. So it's really a great little course. I was actually very impressed with it.
Great. Well, if anybody does have questions, you know how to get a hold of me. You should have access to my email and let me know if there are any questions about any of this stuff. I'm always ready to answer questions.
If not, you can always shoot me an email and I'll forward it on.
Absolutely.
All right. Sounds like we've had a good night tonight, folks. Great lecture, Dr. Phillips. And everybody,
Thank
good
you.
night.
I got to get on that